TopMedTalk.
Welcome to TopMedTalk. This piece is entitled Monitoring Patient Safety. TopMedTalk is listened to in over 100 countries. It has thousands of episodes available to you in its free archive, and it's one of the longest running weekly perioperative medicine podcasts in the world. More and more people are joining us each day, and if you've never heard us before, maybe this program is a good place to start. This piece is a look at some of the work we've done on the subject of patient safety. This program is a collection of clips taken from various TopMedTalk episodes on the subject. The links to those fuller conversations, all of which we recommend, are in the show notes.
I'm very passionate about patient monitoring, trying to enhance safety.
To set the tone for this conversation, we're going to begin with a clip from Meera Joshi. She's a specialist registrar at Ashford and St Peter's Hospital NHS Foundation Trust and clinical research fellow in the Department of Surgery, Cancer at Imperial College London. But she sets the tone beautifully with this quote from one of the conversations we've had previously here on TopMedTalk.
Challenges that we're having in the healthcare system in the UK are challenges that are faced in many countries in terms of workforce shortages, high numbers of agency staff and so on. So I think all of these factors are to play, but anything that we can do to enhance safety, I think is really important. Continuous monitoring is one sort of part of this big giant puzzle. But with monitoring devices and how well developed they are, it's so much more improved to what they had before. So anything that we can do to improve that, I think, is really the key. Especially now with patients accepting wearables. People are used to monitoring step counts and sleep cycles. And it's not, it doesn't feel perhaps as intrusive as it may have felt 40 or 50 years ago. Now it's actually, we're looking to, and I think if you monitor something, you can keep an eye on it. We actually know what's going on. So for me, data is really the key, and having a bigger data set as possible. We know that looking at some of the research that we were doing, wearable sensors can pick up deterioration significantly quicker to the setting. And we did this in a quiet alerting. So we weren't alerting in real time, and we looked at the data retrospectively to see how quick is a sensor compared to nursing observations. And many a time it can pick it up hours and hours before, because it's having such a wealth of data set with lots of monitoring as opposed to static measurements.
COVID-19 and the lockdowns that accompanied it, of course, qualify patient monitoring in the perioperative setting. And as a result of that, we've been listening to a lot of research and discussion here on TopMedTalk about the future of monitoring patient safety. Let's have a listen to J.W. Beard, Chief Medical Officer of GE Patient Care Solutions. He's also on the Anesthesia Patient Safety Foundation Board of Directors.
APSF makes practice recommendations that are produced and circulated widely enough, and the organization is so well respected that it really impacts practice, and it's become a very influential organization. And I'm happy to, we met at the Stolte conference. I'm also very pleased to serve on the board of directors and the committee on technology also. Yeah. And so it's an organization that's very much worthy of the support of me and my role, and I think just clinicians globally.
For sure.
Links, of course, to this fuller conversation are available in TopMedTalk's show notes. More now from the same conversation, but this time Jeffrey Feldman, attending anesthesiologist, Children's Hospital of Philadelphia, and Professor of Clinical Anesthesiology at the Perelman School of Medicine at the University of Pennsylvania. Also a member of the Board of Directors of the Anesthesia Patient Safety Foundation, Jeffrey had this to say.
On the monitoring side, that's our most recent effort. It started about 3 or 4 years ago, actually, with one of our international committee members, Jan Hendricks. He came to one of the meetings with the observation that if you looked at monitoring recommendations from professional organizations around the world, they were very different. Mm. And of course, patient physiology and safety considerations are not that different around the world. Uh-huh. And there were some organizations that really were a little behind. And so we took a look at a comparative review of those things, tried to bring everybody up to the same playing field with our recommendations. I think specifically we really targeted recommendations around EEG monitoring because of concerns for awareness, particularly with intravenous anesthetics in patients who've received muscle relaxants. So we came out with very specific recommendations around that. Neuromuscular blockade monitoring has been a mission of the APSF for some time. Yes. And so we came out with very specific recommendations that you should always do that when you're using a relaxant, and preferably with a quantitative device. And we're going to be doing some more work around that going forward. And then there were some other lapses. For example, in the United States, anesthetic concentration monitoring was not considered standard. And so we've tried to move that bar if we can with our recommendations.
Because I'm sort of old enough to remember the minimal monitoring standards coming in.
Yeah.
And that, what was that, the 80s?
So late 80s, yeah.
80, which was started with, it's a good idea if you stay in the room. That's seriously, I'm not joking.
No, it's right. Got to walk, crawl before we can walk.
Exactly. And it went on to say, end-tidal CO2 monitoring, ECG, blood pressure, pulse oximetry, which then became a standard, which is good for everybody. And I think that did become globalized, but there's so much has happened in between.
We highly recommend the follow discussion, which is available for download for free here on TopMedTalk. Patient safety, patient monitoring, and ultimately research-based, data-driven recommendations are discussed in detail.
Whatever it takes to move patient safety forward, we're opening our arms. And
so it's never a blame game. It's how do we work together to make the world a safer place?
Move things forward, absolutely, yeah.
And the APSF, really, they're walking the walk, because at the conference, whenever we were there were people from multidisciplinary groups, and different types of providers.
They all had a voice.
And they all had a voice. Everyone had a part on the stage and presentations and conversation. It was a really wonderful experience. So kudos to you.
Thank you. And it is very purposeful. And, JW mentioned the practice recommendations.
Yes.
So just last February, we came out with some new recommendations around patient monitoring. If we were to wait for the professional organizations to move forward with that, it's a very long process. It's not a critique. It's just part of their process. But what I like about being involved in the APSF is we can bring experts together. We can come up with opinions that are well considered, and then put recommendations out there that I think are really helpful to people in practice.
Perioperative medicine is, of course, driven by patient safety and an attempt to take a wider view of medical practices into context. New technology elevates the possibilities here by allowing more context into the picture with modern forms of patient monitoring.
So staff already identified problems with current monitoring. Sometimes it could be really simple, like on the ward at the moment, they only had 2 transportable OBS machines and one of them was broken. So just the logistics of having to wait for the next bed to be completed by that normally they're very junior healthcare assistants doing the observations in patients, or very junior nurses. Could be very simple things like that to also miss deterioration. So by that, certain things that were suggested in this work that we were doing was really looking at nighttime monitoring and over the weekend, where we knew that ideally we'd have great cover throughout the patient stay, but we know that there are certain times, such as a weekend and overnight, where staffing levels aren't as high as during the day. And that was something that staff felt that this could really pick up deterioration. But there is also some data to say that people are scared to raise the alarm. And actually, some of the more junior members of the team were saying that a device like this could help give us the confidence to raise the alarm. And also, a lot of them felt like it could improve patient safety and very much be the future of monitoring. I think, healthcare has changed so much in the last 40 to 50 years at groundbreaking levels. But now the way that we're monitoring patients of observations of 4 to 5 hours apart often perhaps could be better than what we're doing. And I'm just looking to see if new technologies can help support that, but also at the same time, keep patients ambulating, because we don't want them sitting in beds lined up to lots of wires, checking lots of things. We want them to be able to move around and get back to their baseline, or get home ideally as soon as possible.
Meera Joshi again, Specialist Registrar, Ashford and St Peter's Hospital NHS Foundation Trust. Meera is carrying out research into this area, and the conversation we had with her gives more detail, but here's an outline.
So we were trying to see, are there any novel new devices or certainly wearable sensors that we can use to help see if we can pick up deterioration quicker and really use them as an adjunct to care. So there's no, brilliant bedside care is fantastic, but it's what happens when we don't have enough nurses on the ward? What happens when there's a delay or some of our team have gone on a break? And these are the sort of what happens during the handover time when one patient's become sick. The growth of wearable sensors has really accelerated massively over the last sort of 15 to 20 years with smaller devices that are able to detect greater vital sign parameters. Not only that, often the devices have buffers in them or algorithms that can make sure that only good quality data is getting through. Because as we know, a lot of data from the ITU setting in terms of the alerts being generated, we want to make sure that the numbers that are coming through are just really related to only a sick person falls through the system and a nurse will get alerted to that. So some of my research was looking at new wearable technology in critically unwell patients. So we did most of our studies at Imperial College London in a busy district general hospital, West Middlesex Hospital, which is part of the Chelsea and Westminster Hospital NHS Foundation Trust. And through that hospital, we recruited a huge numbers of patients, both medical and surgical. And we were looking at really the acutely unwell patients with all sorts of comorbidities, both in medicine and surgery, but all sorts of medical problems. And then hopefully they were having a wearable sensor as well as their standard of care. And then we were looking at, firstly, is it feasible? I think it's fine for monitoring patients that are stationary, but what happens with the ambulating patients? And how do we monitor them effectively? What is the quality of the data being transmitted? What we wanted to check are we having huge amounts of data dropout, which is what we didn't want. And what happens if, the patient goes to the bathroom? So that was reliability was one part of the work that we were doing. And the second part of the work we were doing was really looking at end user feedback, because it's really both. You've got to have both. So we really wanted to know, what do patients think about it and what do staff think about it? So we did some questionnaire and interview studies in sort of both groups to see what they felt about this kind of monitoring that we were doing, because if it wasn't comfortable for patients, they were unable to wear it. It was going to come off pretty quickly, I'd say. Likewise, if the healthcare team, both from junior doctors, junior nurses, right to senior matrons and senior attendings, if they weren't down with it, then it also wasn't going to work.
The bottom line in this conversation is the way we're monitoring patients can, thanks to new technology, now be improved.
For the patient undergoing surgery in the United States, generally we've had a massive improvement, around 1 in 2 to 1 in 300,000 incidents of mortality versus in the 70s of 1 in 10,000 or so mortality. And that's largely been based on leadership. It's been based on enhanced monitoring, implementation of standards of care.
Dr. Stephen Greenberg, Vice Chair of Research and Education at the Anesthesia Department of Endeavor Health, Chicago. Vice President also of the Anesthesia Patient Safety Foundation. He gives us some perspective.
So a lot of that has really advanced perioperative safety, but we're still not there yet. And I think, there are some topics that we can still do better on. Communication and medical error are really tied together and are still, I think, an epidemic in the U.S. healthcare and beyond. Dr. Warner, our past president, published an article in ANA about, he surveyed 13 countries or so about what does safety mean to them and where were we missing, and whether it was low income or upper middle income or highly developed nations, they all said teamwork, culture of safety, collaboration, and communication. We can all do better in that domain. And that might be enhanced by using checklists, propagating and promoting globalization of standardization. So I think there's still ways that we can sort of move the bar even more forward than the instance that we have in the United States. And there is still a disparity gap in the delivery of healthcare even within the United States. in minority populations. And we saw that so evident during COVID, particularly folks in minority populations really suffered significantly from not getting the appropriate health care that they might need.
So once again, a theme emerging as the advantages of monitoring cut across culture and hierarchy to facilitate a data-driven practice.
Because there's a cultural issue that goes on in many countries around the world, including the U.S., where folks are still reticent to speak up when they see something that is abnormal. And for whatever reason, it's something we still need to work on. And so if we develop these systems that objectively say, this is when you absolutely need to speak up, it might take that hierarchical culture or failure to, say something's going wrong when it really is out of the picture, which really just harms patients because it delays recognition and treatment or appropriate treatment.
Dr. Greenberg then takes the opportunity to drive home the fact that data, in a sense, is destiny. The more information we have, the more we can see problems before they emerge, particularly as this conversation takes place in the shadow of an oncoming AI revolution.
The next frontier is how we can leverage artificial intelligence, machine learning to capture all of this data that's being missed and then actually extrapolating it, validating it, and using it for improving patient safety. Because you're right, there's huge gaps. We know that even when we talk about respiratory depression, that most of those cases occur one day after surgery, and most of them occur in the first few hours hitting the floor because of lack of monitoring and lack of human resources to detect these unwanted adverse events. So opportunities that I think with new focused technologies, but also integrating that technology, I don't think we can get rid of the human to interpret what's going on. But I think that might be able to serve a huge, broad group of folks and also be able to look at what's happening between the interims missed monitoring events. So I think, we had our last Tool Tank conference actually was on emerging technologies. And you heard a lot about artificial intelligence, machine learning. And it's probably the hottest trend. And many people believe in the next 5-10 years, there will be some type of standard or at least significant guideline on how to leverage these types of specific technologies to improve patient safety and care.
Sadia Khan, consultant cardiologist at West Middlesex University Hospital.
So traditionally, obviously, we've not even had standardized models or methods of monitoring patients when they're in the ward areas. And it's not that long ago since we started systematic track and trigger systems. For example, the United Kingdom, the National Early Warning Score, News 2, as we now call it, isn't that old in terms of how long ago we've implemented it. But despite that, we know that challenges remain in people's ability to be able to monitor things. So respiratory rate would be the classic example of something that we clinicians actually find really difficult to do correctly. So there's that, but there's also the element of what's happened in terms of acuity and staffing. So for me, who's been on the wards for longer than I can care to remember, think back, we used to have empty beds on wards. I can't remember the last time we've had anything less than 85-90% occupancy. And I also can't remember when we had simple things to look after. So these challenges mean that our patient safety challenge will get bigger and bigger.
Marco Lucetti, anesthesiologist and medical director for patient care solutions at GE Healthcare, puts the concept of patient deterioration into its proper context.
Everyone who has been involved in this knows very well that when you get a call from the ward, a patient is deteriorating and you go there, you never know what you can find, what the situation is, and it's always difficult to manage patient in that moment of crisis. So what we need to do is to prevent patients from suddenly deteriorating. Actually, they are not suddenly deteriorating, they are suddenly found to be deteriorated. That's the crucial point.
Frank Overdyke, Professor of Anesthesiology, Charleston, South Carolina.
This is first about our responsibility to take care of our patients properly. We are using a standard of care of monitoring. Typically is to collect vital signs every 4 hours. You know where that came from? That's that's a standard that's completely outdated. There was never any data that showed that was a proper monitoring interval. You may say maybe 2 hours is better. We've tried to move to 2 hours, but really in this day and age, when everyone is wearing a device that collects their vital signs continuously, that's why couldn't we? That's the least we can do in a hospital where people want to feel safe, that we have the responsibility to do that. So it's not, you imply that it's elective, we need to do a little better. Now, this is a baseline responsibility that we have, that no one is found undetected in a bad deterioration in the hospital. That's my opinion about that. Sadia?
So I'm just going to pick up with Frank. So I agree absolutely that patient outcome and patient care is our number one priority. But I also like to bring it back to the staff. So we've all lived through a terrible, difficult, unimaginable 2.5 years, thinking that we'd get to the other side of this and maybe things would be easier, but it's not. So across the globe, staffing in healthcare is an ongoing workforce challenge. And that issue of, do we invest in more staff? Yes, absolutely we do. But where those staff come from, how we support those who are already in our systems working, and how we make technology make the lives of staff better, has to be on the same scale as patient outcomes. And for me, this isn't a technology replacement. This is technology enabling staff to do what staff do best, which is care for patients.
Modernising patient monitoring starts to look essential from some perspectives in this light.
We have a responsibility in the hospital to take care of everybody, not just most patients. Every single patient. Nobody should suffer preventable harm in the hospital. And I think with what the technology is getting there, our attitude needs to keep up.
Interesting. So the patients will drag us to success.
Nice way to put it.
It's a conversation that will continue here on TopMedTalk, and hopefully it's sparked a few thoughts in your mind. Thanks for listening to TopMedTalk. Today's piece, like all of our pieces, is intended to be the beginning of a conversation rather than the final word. Links to all of our conversations and more are available topmedtalk.com, or check out the show notes on the podcast provider.
TopMedTalk.
Thanks for downloading TopMedTalk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.